Good morning, students. Our lecture today is also on the subject of common jawbone diseases, which is the non-odontogenic tumors. Non-odontogenic tumors, they develop from epithelium or mesenchymal tissue of a wide variety of tissue in the body. They may originate in the facial bone, but they also may develop in other sites other than the head and neck. This is a differentiation from odontogenic tumors. Odontogenic tumors occurs exclusively in the jawbone, while non-odontogenic tumors, like we will see in this lecture, we will find them also in the in other sites, like in long bones, in femur, tibia, any other location. They are not exclusive for jaw bones. Some of these tumors have a little clinical significance, may require nothing more than local observation, while other tumors, they are serious, malignant, and needs a multimodal therapy and have a very poor prognosis. According to World Health Organization classification in 2017, it classifies non-odontogenic tumors into fibroosseous and osteochondromatous lesion, benign maxillofacial bone and cartilage tumors, giant cell lesions, and simple bone cysts, malignant maxillofacial bone, and cartilage tumors. These are the subjects that we will discuss in today's lecture. The first group is benign fibroosseous and osteochondromatous lesion. The common characteristic features for all fibroosseous lesion is the replacement of normal bone with tissue composed of collagen fibers and fibroblasts that contain varying amount of mineralized substances, which can be either these mineralized substances can be either bone or cementum-like material. From its name, fibro, they have fibrous tissue, collagen fibers, osseous, which mean have mineralized tissue like bone or cementum. The first type of this lesion is fibrous dysplasia. What is fibrous dysplasia? It is a developmental skeletal condition in which the normal bone is replaced by poorly organized bone and fibrous tissue. It can be subdivided into 4 different forms. Either monostotic fibrous dysplasia affecting only one bone, polystotic fibrous dysplasia affecting multiple bones, Albright syndrome, in which multiple lesions are associated with hyperpigmentation, endocrine disturbances, precocious puberty, and hyperthyroidism. The fourth subdivision is the craniofacial fibrous dysplasia, which is confined to the bone of the craniofacial complex. What we see in this type, we will see bone expansion, which cause compression on the nerves and the blood vessels. Usually, the most affected is the optic canal is narrowed by this fibrous dysplasia, and sometimes may cause vision loss, but it can be relieved by orbital decompression. The jaws are commonly associated with all these forms, that we said them. Fibrous dysplasia appears to be a lesion that burns itself out, which means it is a self-limiting lesion. When the patient reach his teens or early 20s, the activity of the disease will dramatically be lower. When we see these lesions in the jaws, the onset is usually during the first and second decades with no gender predilection. The location in the craniofacial form, the maxilla, the zygoma, sphenoid, frontal bone, nasal bone, and the base of the skull are the most commonly affected. When the maxilla appear to be affected more than the mandible. Clinically, it appears as a painless swelling of the involved bone. Like here we have a fibrous dysplasia in the maxilla, a painless swelling. Changes in the bone can range from mild expansion, like we see here, being primarily a cosmetic issue, to a large expansion that affect adjacent structures. Sometimes it can cause tooth displacement. In the radiograph, the classical appearance is a ground glass opacity, like we see here in the samurai. Ground glass opacity, in this CT, like we see in this CT. ground glass مثل الزجاج المطحون, ground glass appearance without a clearly defined border. We can't see a defined border for the lesion. The treatment for fibrous dysplasia, usually it doesn't have any treatment. Like we said, the lesion is self-limiting. Surgery is considered only for cosmetic issue. If the expansion is so large, we can do shaving of the bone. Because why we don't need the treatment, I stress to this point, because the disease tend to slow after skeletal maturation is complete. Another fibroosseous lesion is Acifying Fibroma. It is a benign bone neoplasm that affects the jaw and the bones of the craniofacial region. It contains a vascular cellular fibrous trauma with reticular bone trabeculae and cementum-like sphericals. It affects patients in the third and fourth decade of life with a female predilection. It shows preference for the mandible and favoring the molar and the premolar region, like we see here. Clinically, smaller lesions often appear asymptomatic and detected incidentally on routine dental radiographs, while large lesions cause facial swelling, which became clinically apparent. This is the patient clinical appearance of Acifying Fibroma. This is the radiographical picture of the same patient, of this patient. Radiographically, the degree of radiolucency or radioopacity depends on the amount of calcified material, bone or cementum, within the lesion. So it could be completely radiolucent or completely radioopaque or mixed. Like in this case, we see mixed radioopacity. It's not completely radiolucent and not completely radioopaque, with destruction of the lower border of the mandible. And as we see, this is a large lesion. Acifying fibroma tend to be a large lesion. Complete surgical excision is the treatment of choice, because incomplete removal will result in increase the recurrence rate. These tumors, when they are in a close approximation to vital structures, like in this case, it is in a close approximation to the mental nerve and to the inferior alveolar nerve, then they can cause problems. Another fibroosseous lesion is familial gigantiform cementoma. It is a rare, benign, autosomal dominant fibrocemento-osseous lesion, generally limited to the facial bones, characterized by rapid osseous expansion. It's composed of fibroblastic tissue proliferation intermixed with predominantly cementum-like deposits. It often develops during childhood and present itself in the first and second decade of life. Usually involve multiple quadrants with variable expansile lesion, like we said in the previous lecture. The word expansile means expansion, the ability of expansion. Often in the anterior mandible, like we see here this patient. A large bone expansion, often in the anterior mandible. The clinical features usually asymptomatic in the early stages, with a gradual enlargement involve almost the entire mandible, like we see here. It's not confined only to the anterior area, and also in here. Almost eats all the mandible. And may cause severe facial disfigurement, like we see here, interdental spacing, and difficulty in mastication. If we see the anterior teeth here, they are separated, they are floating in the lesion, and there is displacement of some of the teeth. We see here also. In the radiograph, it will appear as an extensive, well-circumscribed, mixed radiolucent radiopaque mass. Like we see here, these are areas of radioopacity, and these are areas of radiolucency. So it's mixed opacity, well circumscribed. We see here the line between the lesion and the normal bone jaw. The treatment is usually surgical and symptomatic, means if the patient has symptoms, we relieve the symptoms of the patient. The goal of the treatment is to reset the lesion, preserve the jaw, restore its function, reduce the complications associated with the treatment, improve or maintain the patient's quality of life. However, the management of familial gigantiform cementoma is difficult. Why? Because its rapid expansion of the lesion, widespread involvement of the jaw, and associated with a high rate of recurrence. Cemento-osseous dysplasia, it is the most common fibroosseous lesion of the jaw. It is a non-neoplastic lesion of the tooth-bearing areas, generally affecting the mandible more than the maxilla. In this condition, there is a disordered production of bone and cementum-like tissue in the jaw, and the periodontal ligament are suspected to be the origin of the fibrous tissue that found in the cemento-osseous dysplasia. It can be divided into 3 different subcategories according to their clinical and radiographical appearance. The first subcategory is the Preepical Cemento-osseous dysplasia. They are usually occur around 6% of African American females, associated with one tooth or multiple teeth, where in the anterior mandible, one tooth or multiple teeth in the anterior mandible area. Clinically, they present as a circumscribed lesion in the periapical area associated with vital teeth. This gives us some differentiation from only the clinical pictures from like an abscess or cyst. The vitality of tooth gives us indication that this is not abscess or cyst. Radiographically, the lesion could be radiolucent, like we see in this picture, or radioapic or of mixed density. Here, radioapic or of mixed density, depending on their stage of development. Often they have an area of radiolucency, a fibrous capsule. These lesions, usually the periapical cementoosseous dysplasia, do not require the treatment. Only routine follow-up is recommended to check the progress of the lesion, with dental radiographs showing the maturation of the lesion of the time. Why they don't require treatment? Because they usually not extensive, after maturation remain in size, and they don't affect the vitality of the teeth. So the other subtype of cementoosseous dysplasia is focal cementoosseous dysplasia. They have a predilection for middle-aged African American females. It is associated with one tooth or one area. This is a differentiation from the periapical. Periapical, it could be one tooth or multiple teeth. In the focal, they are associated with one tooth or one area. Appears in the molar region, in the tooth-bearing area or edentulous area. So this is another differentiation from the periapical. Periapical usually where occur in the anterior mandible. Here occur in the posterior mandible. Whether it is associated with tooth, like this focal lesion, or in edentulous area, like this focal lesion. Clinically, they are usually asymptomatic, non-expansile mass. They don't cause expansion of the bone, with single tooth affected. Radiographically, they appear as well circumscribed radiolucency, or sometimes associated with radioopacity, but also were circumscribed, like we see. This is its boundaries. Usually not exceed the 2 centimeter in diameter. The treatment also is no treatment, only routine follow-up with dental radiographs showing the maturation of lesion of over time. The final subcategory of cementoosseous dysplasia is Fluoride Cementoosseous dysplasia. It has a predilection for middle-aged African American females, usually involve 2 or more quadrants of the jaw. This is a difference from the focal and from the periapical. It involves 2 or more quadrants, like we see here, in the right quadrant, in the left quadrant, also in the upper left quadrant, in upper right quadrant. Clinically, it appears as asymptomatic lesion without expansion of the cortical bone, and therefore no jaw volume increase or any asymmetry. The teeth in the areas affected by the condition show normal color and normal pulp vitality. The lesions may be associated with superimposed infection and osteomyelitis because they have high susceptibility to infection, and also may be associated with idiopathic bone cyst. In the radiographs, they usually appear as either radiolucent, mixed, or radioopic, lesions like we see here. This is a mixed lesion, radio-opic, radiolucent. In here, this is completely radio-opic lesion. In here, this is a radiolucent lesion. They usually present as radio-opic irregular or lobulated mass surrounded by a rim of radiolucency like we see here. Lobulated, radio-opic with a rim of radiolucent mass. The treatment: in the asymptomatic cases, there is no treatment required. The patient only usually have regular follow-ups and x-rays. However, in the symptomatic cases, it has been necessary to do surgery to solve the problem. So the treatment for symptomatic cases is radical surgery. It has a favorable prognosis and allow complete healing. The main treatment strategy is to avoid the contact of the affected bone with the oral flora. Like I said, this lesion, the fluoride cemento osseous lesion, has a high susceptibility for infection. Any entrance of bacteria in the area of the lesion can cause infection, inflammation, osteomyelitis. So, the main strategy is to avoid contact of the affected bone with the oral flora, which happen in cases of chronic inflammatory periodontal disease associated with dental bacterial plaque, caries followed by pulp necrosis and then chronic periapical disease, tooth and jaw bone trauma, surgery with extraction or placement of implants. So, endodontic treatment should only be made when we confirm the teeth are dead. They have no vitality. But should be conducted under preventive antibiotic therapy with after a clear diagnosis of a fluoride cemento osseous dysplasia has been made. So, if the patient is diagnosed with the fluoride cemento osseous dysplasia, and like let's say the case doesn't need a treatment, like it is a small lesion, doesn't need treatment, asymptomatic, but there is infection, you should prevent the infection from entering the bone. You have a badly carious tooth, the patient is suffering from pain, you should do endodontic treatment for the tooth. So you should give the patient a heavy preoperative antibiotic and then to do the endodontic treatment to prevent any entrance of microorganism to the lesion area, to prevent. The final type of fibroosseous lesion and osteochondromatous lesion is the osteochondroma. It is an osteocartilaginous exostosis with cartilage-capped exophytic lesion. Usually appear where there is areas of cartilage, so mostly appear in the TMJ area. It is one of the most common benign tumors of axial skeleton. It accounts for approximately 1/3 of the benign bony lesion. Usually develop during childhood, which is the period of most rapid skeletal growth. But once formed, they remain for the rest of the individual life. They doesn't expand, they doesn't grow. They present at any age with a slight male predominance. Location: they most commonly seen, as I said, in the temporomandibular joint, the coronoid or condyle process. It also seen in the cranial base, maxillary sinuses, jaws, ramus, body, and symphysial mandibular region. Clinically, the symptoms may vary depending on the location of the treatment, but the TMJ osteochondroma causes a progressive enlargement of the condyle, like we see here in the CT, the 3D CT. Progressive enlargement of the condyle, usually resulting in facial asymmetry like we see here, facial asymmetry. This area, this is the affected area. We see the expansion, the swelling. This is a flat. The face is asymmetrical. Prognathic deviation of the chin. TMJ dysfunction, limited mouth opening, gross bite to the contralateral side, and malocclusion with open bite on the affected side. Pain is rarely associated with this tumor. The growth is usually slow, causing a gradual displacement and elongation of the mandible. In the radiograph, usually appear as mixed radio-opaque radiolucent lesion with distinct border. Like we see here, it has a distinct border, very defined border, easily identified on panoramic radiograph and on CT. The treatment for osteochondroma, in most instances no treatment is required, but when the symptoms occur, localized excision is recommended. So if there is no symptoms, no problems, we leave it alone. If we have any symptoms like this patient, we need to do a localized excision. The aim of the treatment is to achieve acceptable mouth opening, recover facial symmetry, establish facial harmony and occlusion. The recurrence is unusual for the osteochondroma, which means the recurrence for osteochondroma is very rare. The other category of the non-odontogenic tumors is the benign maxillofacial bone and cartilage tumors. The first one we have is chondroma. Chondroma is a benign tumor of mature hyaline cartilage of mesenchymal origin. It shares some histological feature with low-grade chondrosarcoma. The occurrence of this region in the jaw is extremely rare. It's usually discovered in the third and fourth decade of life with equal gender distribution. The location in the jaws, it involves the anterior maxillary region adjacent to the nasal spine and nasal septum, and in the mandible it involves the symphysis, the body, the coronoid process, and the mandibular condyle. So any area which have a cartilage. Clinically, most chondroma are asymptomatic. They present as a painless, slowly progressive swelling, which sometimes may result in a mucosal ulceration. It can be associated with teeth mobility and root resorption if they occur in the anterior region of the maxilla. When chondroma involve the TMJ, it often goes undetected, or sometimes can be clinically confused with the TMJ dysfunction because of its rarity. The condition may be associated with a variety of symptoms such as clicking, limited mouth opening, deviation, 2 episodes of condylar dislocation. Sometimes it will cause condylar dislocation. In the radiograph, they represent as irregular radiolucent lesion, although foci of calcification may occasionally occur. Because it is a radiolucent lesion, so the best method for X-ray is the CT, and the best one is the 3D CT. We see here enlargement of the head of the condyle. We see here also. The treatment, because of the doubtful nature of the lesion and the possibility of the lesion representing a low-grade chondrosarcoma, the preferred treatment is wide excision of all the lesion with 1 centimeter peripheral margin as a kind of insurance policy. Recurrence is rare. Follow-up period is recommended. Why? Because recurrence with malignant transformation is a possible complication. Osteoma. It is a benign tumor consisting of mature, compact, or cancellous bone. It may arise from the surface of the bone, and we call it peripheral or periosteal osteomas, or centrally within the bone, and we call them endosteal osteoma. Or they could occur within the muscle, and they are called extraskeletal soft tissue osteoma. Osteoma is usually discovered during the second and fifth decade of life, although they have noted in all age groups. Males usually more affected than females. They are most commonly found in the skull and facial bone, mainly the frontal bone, mandible, or paranasal sinuses. Clinically, the periosteal osteoma usually present as asymptomatic. This is a periosteal osteoma, usually appear as asymptomatic, slow-growing bony mass ranging from 1 to 4 centimeter in diameter. Endosteal osteoma, they are usually asymptomatic and often noted on routine radiograph. Endosteal osteomas don't cause any bone changes or any bone expansion, so they cannot be diagnosed by their clinical features, only by their radiographical features. In the radiograph, the endosteal osteoma appear as a well-circumscribed sclerotic radioopic mass, like we see here, our circumscribed sclerotic radioopic mass. This is the peripheral, this is the endosteal, this is the peripheral. It is not in the bone, it is on the bone. This is a superimposition of the lesion. This is bone, so it is superimposed on the alveolar bone, so it appears as a sclerotic mass on the bone. The treatment of osteoma is surgical excision. The recurrence is rare, and there is no report for malignant transformation. The post-operative follow-up should include periodic clinical and radiographical studies. Of the osteoma is Gardner Syndrome. What is Gardner Syndrome? It is an autosomal dominant condition in which the patient have intestinal polyposis, multiple osteomas. Like we see here, the patient is suffering from multiple osteomas. Usually endosteal and fibromas of the skin, epidermal cyst, impacted teeth, and odontomas. The clinical significance. Why it is clinically significant, this syndrome? Because the presence of intestinal polyposis usually frequently occur in the colon and rectum, and they are pre-malignant and have a very high rate of malignant transformation. The associated osteomas are often found in the jaw, particularly in the angle region. Like we see here, there are some small osteomas, as well as in the facial bone and long bone. It has been suggested that if the patient come to your clinic and you find multiple mandibular osteomas, you should investigate the possibility of Gardner syndrome. Investigation include detailed history of GIT disturbances. If positive, follow-up colonoscopy. If the diagnosis is confirmed, prophylactic colonectomy should be performed to prevent the malignant transformation. Another lesion is the melanotic neuroectodermal tumor of the infancy. It is a very rare, rapidly growing, pigmented neoplasm of neural crest cell origin. It usually occurs in the infants younger than 1 year and have a slight malopredilection. It predominantly involves the craniofacial sites in more than 90% of the cases and most commonly arise in the maxilla, like this patient, this small patient. They clinically present as enlarging, painless, firm mass, often underlying an intact epithelium surface, and it may have a black or a blue discoloration. In the radiograph, this is an MRI for the patient. This is the lesion. In the radiograph, it is usually a well-demarcated radiolucent lesion within the bone, which may have features concerning for local destruction, suggesting malignant process. The treatment, because of its rapid and infiltrative nature and a high local recurrence rate, as well as the existence of rare malignant examples, early diagnosis with complete excision is necessary for best clinical outcome. Chondroblastoma. It is an uncommon tumor typically occur at the end of long bones in skeletally immature persons, which means in the childhood and teenage patient. Chondroblastoma arise in the craniofacial bones is very rare, representing about 6% of all chondroblastoma. Usually, the chondroblastoma of the skull, the patients tend to be older than that for chondroblastoma in the long bone, with the mean age about 44 years, with a slight male predilection. The most common skull osteoblastoma is in the temporal bone, followed by the mandible. When the tumor is located in the temporal bone, the most complaint, this is a TMJ, chondroblastoma. When the tumor is located in the temporal bone, the most frequent complaints usually include pain, swelling, plugging sensation in the ear, and hearing loss. In the case of TMJ chondroblastoma, restriction of jaw motion or facial swelling is more prominent than the pain. This is a TMJ chondroblastoma. In the radiograph, they are represented by a resorbative defect or by condylar enlargement, like we see here, often associated with thinning cortex. MRI, it is the more accurately radiological option in these cases. This is an MRI for this patient, and this is the lesion, the chondroblastoma. The treatment is complete surgical resection. It is the standard procedure for the treatment of TMJ chondroblastoma. Achondromiczoid Fibroma. It is a benign bone tumor originating from cartilage tissue that's characterized by both chondroid and myxoid differentiation. It is most commonly seen in the metaphysis of long bone. Only 1% of the cases has been reported to occur in the head and neck. It most commonly found in the second and third decade of life, more prevalent in males, frequently presenting in the mandible more than the maxilla, and less frequently in the base of the skull. Clinically, usually range from, according to the area involved, and generally associated with long-standing history of non-specific symptoms like pain, swelling, edema, and possibly palpable soft tissue mass, resulting in restriction of the movement and more rarely pathological fracture. Usually, it appears as an osseous mass or destructive mass. This is another patient. We see It causes destruction in the ramus of the mandible. Osseous destructive mass, well defined, lobulated, with partial cortical erosion and separations and septations are viewed. Sometimes if we have a more clear OPG, we can see septas. The treatment is usually by surgical resection, local resection or simple curettage, also possible, but it have the tendency to cause recurrences. After simple curettage, the recurrence rate usually about 12% to 25%. So, extensive focal or total resection of the affected bone can reduce the recurrence, and it is the most. Osteoid Osteoma. It is a unique benign tumor of the bone, rarely described in the jaw, characterized by extensive formation of unmineralized bone matrix. It also occurs in the second and third decade of life with male predominance. The location, the mandible, is more affected than the maxilla, like we see here. Clinically, local pain. This is the differentiation from osteoblastoma, which sometimes there will be confusion between osteoid osteoma and osteoblastoma. So the differentiation is the pain in osteoid osteoma. Local pain that is dull, throbbing, and intermittent is the major clinical feature, usually worse at night. If the lesion located near the cortex, it will produce a localized tender swelling. The pain is usually relieved by aspirin. This is also a diagnostic feature. If we have a swelling, a hard swelling like this, associated with pain, dull throbbing, which is worse and worsen at the night, relieved by aspirin, this is the most common diagnosis is osteoid osteoma. In the radiograph, the lesion usually shows as a round or ovoid lesion that is more radiolucent than radio-opaque, like we see here, a radiolucent bone, less than 2 centimeters in diameter, with a small radiolucent rim around it, and walled off by a sclerotic bone. The treatment usually is conservative surgical excision. Normally, once the lesion is excised, they do not. Osteoblastoma. It is a benign tumor of bone, occurs primarily in the vertebrae and long bone, but it has been described in the jaws. It's characterized by osteoid and bone formation with the presence of numerous osteoblasts. They usually occur in the second decade of life, rarely seen after 30 years. Male is usually more affected than a female. Usually in the head and neck, the mandible is the most affected site. Clinically, it appears as a rapidly growing swelling, usually more than 2 centimeters in diameter. This is also a differentiation from osteoid osteoma. Osteoid osteoma less than 2 centimeters in diameter. Osteoblastoma is usually more than 2 centimeters in diameter. And the predominant feature is pain, which is generally localized to the lesion itself. The pain is not relieved by non-steroidal anti-inflammatory drugs. This is the differentiation. Osteoid osteoma, the pain was relieved by aspirin. Here, the pain is not relieved by analgesic. In the radiograph, they appear as a well-circumscribed lesion with thin radiolucency surrounding it, with variable amount of calcification. This is all the lesion. This is extended until here. The treatment is usually complete surgical excision is the only treatment with a good prognosis. Recurrence is rare but have been reported and may necessitate a more aggressive treatment such as in block resection. Dysmoplastic fibroma is considered as a benign yet locally aggressive intraosseous tumor of fibroblastic origin. It represents the osseous counterpart of soft tissue aggressive fibromatosis. It usually occurs under 30 years of age. The incidence of the jaw is usually equal in male and female. Its location is more common in the mandible in the posterior area. Clinically, most present as a slow-growing asymptomatic swelling. Like we see here, there is a slight expansion of the bone. Other symptoms include facial asymmetry, displacement or root divergent, like we see here. It causes displacement of the lower 8. This is not the normal position of the lower 8. It is displaced by the lesion. So displacement or root divergent, pain, TMJ dysfunction, malocclusion, and sometimes tooth mobility. In radiograph, it appears as a radiolucent lesion of ill-defined border, non-sclerotic border. Cortical expansion, like we see here, there is a cortical expansion and cortical thinning often noted. With aggressive tumor, we sometimes see also cortical erosion and perforation. The treatment is usually surgical resection and radiotherapy if necessary. Pharmacological treatment also recommended. Due to its high tendency to local recurrence, so we should have a long follow-up period. It should be at least 3 years. Another type of non-odontogenic tumors is the giant cell lesions and simple bone cysts. Giant cell lesions are a group of lesions that occur in the jaw and contain giant cell in them. The first type is central giant cell granuloma. It is an uncommon, histologically benign but locally aggressive and destructive osteolytic lesion of osteoclastic origin that occur in the craniofacial region, especially in the jaw bones. It consists of cellular fibrous tissue which contain multiple foci of hemorrhage, aggregation of multinucleated giant cells, and some trabeculae of woven bone. Usually affect young patients under the age of 30 with female predilection. The mandible is more frequently affected than the maxilla, with the anterior part is the main location. Clinically, central giant cell granuloma behave variably, exhibiting characteristics ranging from asymptomatic and slowly growing to aggressive and rapid hollowing out of the bone, with cortical expansion, thinning, and perforation, root resorption, displacement of adjacent teeth, including accompanied by pain. The lesion usually encapsulated, so it expands, pushing away and displacing adjacent structures. Like we see here, it causes displacement. The lesion is extending from here to here, causing displacement of the teeth, resorption of teeth, expansion of the bone, thinning of the cortex. Here we have a perforation of the cortex. In the radiographs, it appears as multilocular radiolucency, like we see multilocular radiolucency with scalloped margin because the lesion is entered between the teeth, and a honeycomb or soap bubble appearance. هذا المنظر نشبهه بمثل فقاعات الصابون or الهونيكومب. Also, like we said, teeth displaced, root resorbed. The management compromises of both surgical and non-surgical treatment. The surgical treatment include encapsulation, curettage, peripheral osteotomy, and in-block resection. while the non-surgical treatment, it include the injection of intralesional injection of steroid. We inject in the lesion steroids because of its nature. We don't know it is inflammatory, is it reactive, is it a benign, is it what is the nature of it. So it have a multimodal therapy. So beside the surgical, we have pharmacological treatment. Like I said, first, if we suspect it is inflammatory, so we inject steroids, or we inject, or sometimes we suspect it's hormonal, so we inject calcitonin, which is the antagonist for parathormone. Or sometimes we inject interferon alpha, which inhibit the osteoclastic activity because of its anti-angiogenic effect. Because these lesions are usually hemorrhagic, have a lot of blood vessels. We inject interferon alpha because of its anti-angiogenesis effect. It is associated with a high recurrence rate between 13 to 49%. The more aggressive lesion, the higher chances of its recurrence. And as I said, why it's high recurrence? Because it's difficult to resect the lesion. The difficulty in the resection of the lesion, it's also there will be, you will suspect, you will have a foci of lesion. That peripheral giant cell granuloma, it is the most common oral giant cell lesion. It is a non-neoplastic tumor reactive lesion occurring exclusively on the gingiva or alveolar crest, containing multinucleated giant cells in the background of mononuclear stromal cells and extravasate red blood cells. It occurs throughout life with peak incidence in the mixed dentition years and in the age group between 30 and 40 years. It is also more common in female. Usually, the mandible is more affected than the maxilla. Clinically, it appears as a painless, soft, extraosseous mass with a bluish red color. It can become large, usually reach to 2 centimeters in size. Its clinical appearance similar to the more common pyogenic granuloma, although the peripheral giant cell granuloma often more bluish purple compared with the bright red color of the pyogenic granuloma. Because the peripheral giant cell granuloma occur extraosseous, so there is no radiographical appearance, but sometimes we see cupping or superficial resorption of the underlying alveolar bone under the lesion. The treatment, the lesion is usually self-limiting, so the recommended management aim at elimination of the entire base of the growth by surgical excision with the base of the lesion and eliminating any local irritating factor. Superficial resection can lead to recurrences. Most lesions respond favorably to complete surgical excision with exposure of bony wall. So when I do excision, I reach to the bone, excise all the lesion reaching to the bone. This is the complete surgical resection of peripheral giant cell granuloma. Chiropsism. It is a rare disease of autosomal dominant inheritance characteristic by painless, frequently symmetrical enlargement of both jaws as a result of replacement of the bone by fibrous tissue. It typically occurs in the ages between 2 and 7. It affects males and females equally. The mandible or the maxilla, sometimes both, sometimes only the maxilla, sometimes only the mandible is affected. The symptoms include enlargement of the face, due to swelling of the jaw, which could be bilateral in most cases. Bone consistency of the lesion. When I palpate the lesion, I see bone consistency. It's not fibrous consistency. Intact mucosa. The face is rounded with upturned eyes. The eyes are look upward, giving the patient the cherubic appearance due to the maxillary involvement. So from this appearance, it came the name cherubism. There is no pain, but it is associated with submandibular and cervical lymph node enlargement, especially in the early stages. We see several dental alterations in the case of cherubism. We see early exfoliation of deciduous teeth, impaction or displacement of teeth which radiographically seem as floating, like we see here. These teeth are floating. Ectopic tooth eruption, agenesis of permanent teeth, mainly the second and third molar due to the involution of their germs. Root resorption of existing teeth also observed. Radiographically, it's characterized by an extensive radiolucent, generally multinucleated, honeycombed lesion, clearly defined by the cortical bone and distributed bilaterally in the mandible and the maxilla. We see here the 3D CT, how the fibrous tissue replaced the bone. This is the CT of the patient. The treatment options include waiting for the disease regression, followed by evaluation of the physiological bone remodeling. Most cases usually regress spontaneously after puberty, so no treatment required. Tooth extraction in areas showing fibrous alterations, cosmetic osteoplasty of the affected jaws after regression of the disease activity or in cases of facial impairment, curettage of the lesion, and the treatment. Aneurysmal bone cyst. It is a benign osteolytic, rapidly growing, expansive hemorrhagic bone lesion. Usually favors long bones, such as femur and tibia. The craniofacial bones are rarely affected, usually accounting between 2 to 12% of all aneurysmal bony cysts. Most commonly seen in the first 3 decades, with the peak in the 10 to 20 years, with equal distributions between female and males. The mandible is usually more commonly involved, and the body of mandible and the ramus is the more commonly sites. Clinically appear as a rapidly growing mass, and expansion of the bone is noted in all cases, with cortical perforation seen as an associated feature. In the X-ray, we see the lesion as well circumscribed, radiolucent, multilocular, sub-bubble type lesion. We see also flotation. The teeth are floating in the lesion. The treatment usually include conservative treatment with frequent follow-up, like simple curettage, cryotherapy, excision of the lesion, or radical resection with reconstruction and bone graft, or calcitonin and steroid lesion injection. Usually the recurrence. Simple bone cyst, it is not classified as a true cyst. Why? Because the lesion like an epithelial lining. The definition of cyst, it is a cavity that is lined by an epithelial lining, while here in simple bony cyst, we don't have any epithelial lining. So it is not a true cyst. It is a non-neoplastic intraosseous lesion, could be empty or filled with liquid or connective tissue. It's also called idiopathic bony cyst, traumatic bony cyst, or hemorrhagic bony cyst. Usually found during the second decade of life, can be found also in older ages population over 40 years of age without sex predilection. Usually in the premolar and molar areas of the mandible is the most common site. Most patients are asymptomatic and the lesion is generally discovered incidentally through routine radiographic examination. However, some patients with this lesion may present with pain, swelling, tooth sensitivity. Also, fistula, tooth root resorption, pathological fracture of the mandible, paresthesia, buccal and lingual bony expansion, delay eruption of permanent teeth are also seen. In the radiograph, it is described as a well-defined corticated radiolucency with a scalloping margin between the teeth and root. It shows sometimes displacement and resorption of the adjacent teeth, but it is minimal. Expansion and erosion of the cortical plate sometimes may occur. The treatment surgery is usually the management of choice because it confirms the diagnosis and the treatment by generation. The treatment it will be by generation of a blood clot in the bony cavity of the simple bone cyst. So the bone will regenerate within 6 months. So the surgery it will confirm the diagnosis that is a simple bony cyst, and it will cause collection of a blood and the clot, which will then reorganize into a bone inside the cyst cavity. Careful curettage of the lesion usually lead to progressive bone regeneration and a good prognosis. Recurrence rate is almost neglectable، يعني تقريبا ماكو. The final category is the malignant maxillofacial bone and cartilage tumors. The first, we have Achondrosarcoma. It is a malignant tumor characterized by the formation of cartilage by tumor cells. The involvement of the craniofacial region is very rare. It's account about less than 10% of all chondrosarcomas. Primary chondrosarcoma may arise de novo without any pre-existent lesion, while secondary chondrosarcomas arise from pre-existing chondroma or osteochondroma. It could occur at any age. However, the most frequent presentation is between the 3rd and 6th decade of life. Male are more commonly affected than female. It's usually more common located in the maxilla than the mandible. The maxillary lesions are most occur in the anterior, while the mandibular lesions are occur in the molar and premolar regions. Clinically, the most common presentation is a slowly growing painless mass or swelling. A minority of lesions can cause pain. Lesion involving the alveolar bone may result in displacement and mobility of teeth depending on the location of the tumor. There may be also nasal symptoms, visual disturbances, sensory alterations. Regional lymphadenopathy is very rare. Usually, the radiographical appearance, single or multiple radiolucencies with poorly defined borders. This is the lesion is here. This is the lesion, the chondrosarcoma. Single or multiple radiolucency with poorly defined border, bone destruction associated with calcification or ground glass or sunray appearance. And uniform widening of periodontal ligament of the associated teeth. The tumor may extend well beyond the radiographical margins. We see here it's poorly defined, but maybe the lesion reach here. This is a CT for this patient. This is the lesion. This is the chondrosarcoma. The treatment. Radical surgery is the treatment of choice. As we say, malignant lesions need aggressive treatment. Radiation therapy may be considered in cases of unresectable or residual or recurrent tumors. The prognosis of chondrosarcoma of the jaws is worse than of long bone, and the overall 5-year survival rate for chondrosarcoma of the jaw ranges from 32 to 81%. Mandibular tumors usually have more favorable prognosis than maxillary lesions. Distant metastasis is usually rare. Often the lung is the most common site for metastasis. Lymphadenopathy or lymph node involvement with metastasis is rare, so neck dissection is not recommended for chondrosarcoma of the jaw. The most common cause of death of jaw lesions is uncontrolled local recurrences and extension into adjacent vital structures, and as we know, the head and neck is full of vital structures. Recurrence may occur in 10 to mesenchymal chondrosarcoma. It is a rare variant of chondrosarcoma, accounts about 3 to 9% of all chondrosarcomas, and has high predilection for head and neck region. It is one of the most unusual rare malignant cartilaginous tumor of the bone and soft tissue, with distinct histopathological appearance and biological behavior. Usually occurs between the second and third decade of life with equal distribution between genders. It is located in the craniofacial complex in the maxilla, more common than the mandible. The predominant clinical symptom is a painless mass or swelling. Other symptoms commonly affected such as nasal obstruction, tooth mobility, headache, bleeding, ulceration, facial asymmetry, paresthesia, and trismus. In the radiograph, the lesion will appear as a radiolucency, well or poorly defined, stipple calcification also may be seen. See here, the teeth are floating in the lesion. The treatment for this type of malignancy, the most effective therapeutic modality is wide surgical incision with a tumor-free margin of 2 to 3 centimeters is recommended. Extensive resection has less recurrence and a better survival rate than limited surgical resection. Also, post-operative radiotherapy and chemotherapy offer a good prognosis and eradicate the chances of metastasis. The prognosis is poor because tumors have a tendency for late recurrences, either locally or metastasis. The 5-year survival rates for craniofacial mesenchymal chondrosarcoma are between 40 to 60%. Metastasis is by homogeneous route, and the lung also is the most common site for for metastasis. Recurrence and distant metastasis may take up to 20 years to manifest following the treatment, so another long-term follow-up is required. The final type is the osteosarcoma. It is a rare, highly malignant bony tumor defined by the presence of malignant mesenchymal cells producing osteoid or immature bone. It can develop in a previously irradiated bone as well as a pre-existing bone abnormalities such as patched disease, fibrous dysplasia, and giant cell tumors. Its peak incidence is in the second to fourth decade and is more frequently in fast-growing bones with a slight mere predilection. The mandible affected more than the maxilla, like we see here. Clinically, the most common symptom is swelling and pain. The most common symptom is swelling and pain. Depending on the location of the lesion, the patient may also experience paresthesia, loosening of teeth, nasal obstruction, epistaxis, proptosis, or diplopia. Unfortunately, because some signs and symptoms may be associated with other non-malignant conditions, there is often delay in the diagnosis of osteosarcoma. Its radiographic appearance may vary depending on the destruction of cortical or medullary bone, calcification, and periosteal new bone formation. Accordingly, the radiographic appearance may be purely radiolucent, mixed, or purely radiopaque. This is the tumor, as we see here. It is mixed, radiolucent, and radiopaque. This is the sun. Also, we see sun ray appearance مثل أشعة الشمس. This is the lesion extending up to here. We see also loosening of teeth. If the tumor invades the periosteum, many thin irregular spicules of new bone may develop outward and perpendicular on the surface of the lesion, producing the sun ray appearance, like I said. We see also widening of the periodontal ligament and also widening of the inferior dental canal. With the sun ray effect, usually these signs are pathognomic for the osteosarcoma of jawbone. Wide surgical resection with negative margins is the only treatment that conclusively lead to increased survival. A bony margin of about 3 cm from the radiographic margin is recommended. Surgery with chemotherapy and radiotherapy may be required sometimes. The presence of micrometastasis decides the need for adjuvant therapy. The prognosis for patients with metastatic disease appear to be determined by the site, the number of metastases, as well as the surgical resectability of the metastatic disease. Osteosarcoma of the jaws generally have a better prognosis in comparison with lesion of long bone. The overall 5-year survival rate of head and neck osteosarcoma is between 40 and 70%. Osteosarcoma of the jaws metastases less frequently, and the lung also is the most common site for metastasis. Because regional lymph node metastasis is rare, also neck dissection is not advocated. The main cause of death for osteosarcoma of the jaw is uncontrolled local recurrences. بنهاية هاي المحاضرة نكون نهينا مادة الجوبون ديزيزز. بقدلنا محاضرة واحدة إن شاء الله اللي هي Preepical Surgery، يعني الأبيسكتومي، إن شاء الله ناخذها على الأسبوع القادم وننهي مادة الفصل الأول. Thank you.